Yep, we can hear
Hello.
you.
Yeah, oh, great. Hi, everyone. Welcome to this week's ECVIM lecture without border. Good morning, good afternoon, and good evening. Because I know you all from all over the world. How are you? Do you miss us? It has been a while. Hope you are all well and getting some fresh air and sunshine recently. Yeah. Um, Please accept our apology that these events only have 3-day notice, but we still have received over 900 registrations, which is pretty amazing because our speakers are all doing this for everyone in their spare time. So our session time are always depending on their availability. So the best thing to do is to keep an eye on our notification emails and then make sure it's not in your junk folder. As you can see, we already have arranged and published our next 4 lectures. So please feel free to have a look and register it on our website, xval.com/events. And also we've noticed that many of you are actually very experienced professionals. We've seen senior doctors, consultations, even professors around the world. Well, thank you very much for joining us to make difference together. So we do feel very proud and very grateful. If you or your team or you know someone who may want to speak in our ECVIM lecture without border, please let us know. You are more than welcomed. We hope we can make this platform that we can freely share and co-create our understanding together. Of course, without the border, without the resource restrictions. That's our ECVIM's vision. So today, we will have a very special, a small animal medicine themed clinical club. I'm sure you all remember Fergus Allerton from our last session. Hello, Fergus. So Fergus delivered an amazing lecture on the rational antibiotic use in cats and dogs and answered tons of questions last time. If you missed it, you can still go to our website to watch the video. In this session, in that session, unfortunately, there are hundreds of questions from you guys that remain unanswered. And I promise that we're thinking about ways to address that. Guess what? Our superstar is back today. Yeah, and even better, he also invited his brilliant colleague, Andrew Kent, to join us today. So today's session will be run by both of them. So now, please allow me to give a formal introduction of them first. So Fergus Allerton is a European veterinary specialist in the small animal internal medicine, working at the Willows Veterinary Center and in Referral Service, Solihull, United Kingdom. His main clinical interests are in the gastroenterology and hepatology and immune-mediated disease and antibacterial stewardship. He is currently chairman of the Small Animal Medicine Society and recently edited the latest edition of the British Small Animal Veterinary Association formulary. And our new friend today, Andrew Kent, is a European veterinary specialist in the small animal internal medicine. Andrew graduated from the University of Bristol in 2008 and spent some time in the mixed and then small animal practice before commencing a senior clinical training scholarship in the small animal medicine at the Queen's Veterinary School Hospital, Cambridge in 2012. He moved to Willows Referral Service in Solihull in 2015 and then became a European veterinary specialist in small animal internal medicine in 2016. His main clinical interests are in the gastroenterology, immune-mediated disease, and the urology and the interventional endoscopy. Yeah, so welcome Fergus and Andrew. So this is our lecture schedule for today. We will have an informal chat about some interesting and unusual medical cases with hopefully tons of opportunities for discussion. And also, if you have any remaining questions from our last session, you may probably still have a chance to ask and discuss together as well. So I'm sure you all have received a couple of case presentation half an hour ago. So hopefully you have a chance to look at. So in this section, in this lecture, we will have 2 sections. In part 1, we will have 30 minutes group discussion. So you will be automatically allocated by our ECVIM duck in an outbreak called outbreak room. There will be 8 people in one room, and where you can discuss these cases with our peers, your peers, and try to answer the post questions together. And after about 30 minutes, we will have joined together to have our class discussion. So this part will be led by Fergus and Andrew. So they will give you tons of more information, and opportunities for interaction as well. So just final reminders, everyone will be muted during the session, the part 2, but in the session part 2, please speak as loud as you want, but also act professionally and respectfully. So hopefully we don't see any advertising, spam, or inappropriate comments in our chat box. And please do not share any of your personal data. You don't need to register for your attendance now. And there's 2 ways to ask questions. You can either write down in the box, the chat box, or you can use the raise hand function in the Zoom. Once you've been selected, you are free to ask questions. And also, many of you know that we provide certificate of participation after each lecture. So you must stay for longer than 30 minutes. And like always, our sessions are live streamed on our Twitter account. So if you do expect any technical problems like later, you can go to our Twitter to join us as well. So these are the ways to contact us. The Twitter account is here. So make sure, I don't know, do you need to be our follower in order to see our Twitters? Okay, without further ado, let's start our ECVIM lecture without border today. So Fergus and Andrew, I will hand over this to you.
Great stuff. Thank you very much. Welcome everybody. We're really thrilled to be coming to you here from the UK. It's a beautiful sunny day here, so I hope you're all in similar lovely weather wherever you are, and whatever time of day it is with you. We're really delighted that you're giving up some time to come and chat through some medicine cases with us. As mentioned, we run these sessions in kind of 2 halves. So the first half really gives you an opportunity to have a chat with your colleagues about the cases that we're presenting. We'll just spend 20 minutes, half an hour, something like that, where you'll be in these small groups being able to chat these things through. Essentially in that first half an hour, really the more that you put into it, the more you're likely to get out. So we tend to suggest in those groups that you unmute your microphones, you activate your cameras, and you make some new friends, and you get chatting through those cases and really just learn from each other. And there's lots of nuggets of useful information that we will see during that section. After half an hour or so, we'll pull you back into the main room, and Fergus will talk through the bulk of those cases. At that point in time, we ask you to turn off your cameras and mute your microphones, but still get as stuck in as you can through using the chat box on Zoom. So if you have questions, comments, anything like that, as we're going through, please get them in the chat box. I'll then put any kind of useful points to Fergus, and we'll hopefully have some good discussions around these topics that we're chatting about today. So hopefully that will work okay for everyone. So in general with these things, we want them to be really interactive. The more that you put into them, the more you're likely to get out. So hopefully you've all received the cases. Hopefully Duck and Panda are in the process of setting up the breakout rooms, and we're going to be happy for you to disappear off into those breakout rooms any second. So hopefully you're going to disappear shortly, and we'll call you back in about 20 minutes or so. So enjoy the breakout rooms, make the most of them, and we'll see you in a bit. Welcome back. I think most of you are appearing back with us. I hope that you have had a bit of a chat through some of the cases. I think that we're definitely still learning in terms of the kind of cases that might be useful to you all. So hopefully there's at least bits of these that will be useful to everybody. As I mentioned earlier, what we tend to ask for this next bit is if you can all keep your cameras and microphones off so that we don't get too distracted from what's going on. And Fergus will start talking through these cases over the next half an hour or so, and hopefully we can at least pick out some useful bits and pieces to get chatting about. If you have thoughts, comments, questions, anything whilst he does that, please type those into the chat box at the bottom, and then either I'll answer some of them as we go along, or I'll pose some to Fergus if they're particularly useful bits that it's worth us kind of chatting around. So please get stuck in. Please, the more that you put into this, the more that you're going to get out, and hopefully you find these cases useful and interesting. So Ferg, over to you. Let's hear about the cases.
Right, thank you. Good to see, good to see so many people online. I really hope it is going to be a useful session, and please, as Andy said, do pose your questions as we go along, and if we can present, we've included some polls as well, so we'll be welcoming your input with those as we go along. So this first case is a little dog called Jasper. Why is it not? Hang on. I lost everything. Bear with me. Or will it move? Can you help me? Bear with me 1 second. I just need to go on. I can't even approve that because I've approved it. Try there. Bear with us 1 second, just as while we sort out these computer issues. Andrew might take over the screen for a moment. There we go. Hopefully you can still hear me anyway. I'll share it from here. So. And we'll go back to his... bear with us. So anyway, Jasper, I think you'll have all read this. He's a 4-year-old castrated Labrador. He's been vomiting now for 3 days. He's off food, he's lethargic. He's a classic Labrador, so he will eat anything and everything put in front of him. And also, because he suffers from elbow dysplasia, he's been on non-steroidal anti-inflammatory medication for several months, at least. And when he comes in to see you, you notice that he's got quite dry, tacky mucous membranes. He's got a slightly tachycardic heart. Do you want to swap computers? He's got a tachycardic heart that is associated with a sign of him being slightly hypovolemic. And he's also uncomfortable on abdominal palpation. Right, just, it says Andrew Kent now for me. But hopefully you can hear me now on this. And so Andrew will reply on my behalf via the computer. Right, so we do some in-house blood work. We identify that Jasper is azotaemic. His kidney values are quite markedly increased. In fact, I'd be quite worried to see a creatinine of that level. Whenever you see azotemia, the first classification that I would recommend is trying to define whether this is pre-renal, renal, or post-renal. So what do people think in Jasper? What's your impression? Is this going to be a pre-renal problem? Is he effectively dehydrated? what evidence do we have of dehydration? Think back to the clinical examination, but also look at the urine specific gravity. Is this renal or post-renal? What do we mean by post-renal? Normally we're referring to some form of obstruction to urinary flow, and that's not been reported or documented, or we're referring to bladder rupture or something of that nature. Anyway, in my opinion, because he's so tachycardic and he's got those dry tachymucous membranes, I suspect there is at least a component that is pre-renal, i.e. this dog is dehydrated, and that's going to aggravate, exaggerate the degree of azotemia. But there's also probably at least a part that is going to be renal, especially given that slightly dilute urine specific gravity. We then switch and do a rapid electrolyte panel and identify quite a marked hyponatremia and also a hyperkalemia. What differentials are people? Now, if you get an opportunity to put your differentials in the chat screen, Andy will note whether these are true or not, and highlight if you've got any where people are going the right way. But for me, the important differentials that I would consider, given the history, would include duodenal perforation. So if he has had a foreign body and it's perfed at the level of the duodenum, that can cause this type of electrolyte disturbance. The other one, and the one that I hope people are picking up from an endocrine perspective, a hormonal disease, is going to be Addison's disease. And when you see this picture of electrolyte disturbance, that should be high on your list. We'll do a poll question now, and I'll put out the first poll. So hopefully, please have a go, see what things you can do. Remember, there's more than one answer that's correct here, so feel free to put in all the things that you think you might see in an ECG run in a dog that's got hyperkalemia similar to Jasper. So what sort of things might you see? No one's chosen a normal ECG, but actually you could see a normal ECG every now and again. But you can also see all these other things. There's no wrong answer in this one. So anyone who's put anything or everything is actually correct. So classically with hyperkalemia, we do expect to see a bradycardia, but it's not always there, and it wasn't there in Jasper. We might see a spiked T wave, and we could see a reduction in the size of the magnitude of the P wave, or even a complete disappearance of P wave. And certainly you might see that QRS complex starting to spread out. Now, some people might not have access to electrolytes quickly in-house. So if you have access to an ECG machine instead, you can use the ECG potentially to answer some of the questions and increase or decrease your suspicion of hyperkalemia and get greater ideas of that as well. Anyway, there's the results, and I'm impressed by your knowledge of the ECG and the common abnormalities that one would associate with hyperkalemia. Here's the rest of Jasper's blood work. Anything interesting here? Anything that people would see as being likely or unusual in an Addisonian patient? Any comments on the calcium? Actually, about 25% of Addisonian dogs are going to be hypercalcemic. So I wouldn't be surprised to see that even outside and above the reference range. And when you're seeing high calcium and high phosphate, that's quite unusual because often they work in opposites. So as the calcium goes up, the phosphate will go down. But in this case, they are both high or high normal. That's something that we would commonly associate with Addison's. Low cholesterol as well can be seen with either Addison's or potentially with certain forms of gut disease like lymphangiectasia. Increased liver enzyme activities, we're seeing about 30% of dogs with Addison's. So most likely this is a secondary reactive hepatopathy and not primary liver disease. And actually the magnitude of these liver enzyme increases isn't that great. For me, they're within normal limits. Well, not normal limits, but they're not extravagant, and I wouldn't go worrying too much about the liver at this stage. If you did have, though, azotemia and marked increases in liver enzyme activities, there might be, it might make you think of an infectious disease. And I'm not sure how prevalent this is outside of the UK, and I confess my knowledge of infectious diseases is rather limited to one small island here. But if I mentioned hyperbilirubinemia, so an icteric azotemia dog, does that make people think of any particular infectious disease? I'd be very interested to hear your answers on that, and to see if the sort of spectrum of diseases that you're seeing matches those that we would see in the UK. And I think people are mentioning leptospirosis, which is the one that I would be most familiar with, and that certainly can cause that combination of findings. So if you see increased kidneys and increased liver in the same patient, lepto would be a concern for me. Here's Jasper's hematology. Few abnormalities on this. And remember, Jasper's come in and he's looking quite poorly. So the owner's worried about him. He's been unwell for a few days. He's been vomiting quite a lot, even blood in it, and he looks under the weather. What would we normally expect to see in a poorly animal in terms of their white blood cell differential? What are the classic signs of what we describe as a stress leukogram? So I would expect to see in this patient, I would have been looking for a neutrophilia, a lymphopenia, i.e. low numbers of lymphocytes, and an eosinopenia. And that's not really there. In fact, we're almost seeing a reversal of that in some of these features. So the neutrophils are high normal, but not increased. But unusually, the lymphocytes are very high. And I think that's unexpected. It's a strange finding to see a lymphocytosis in an overtly poorly dog. And for me, that's a cardinal feature of Addison's. So there is a study that was published a few years ago that said if you have a lymphocyte count of that magnitude in your poorly dog, there aren't that many other differentials. I guess you've got certain leukemias, but you might pick that up from looking at a smear and seeing the morphology of those lymphocytes. And normally that would be 50 times 10 to the 9 plus, so much higher numbers. So numbers like this, for me, is highly suggestive of Addison's when it's in a poorly patient. And conversely, if this number is very low, so if it had been a lymphopenia under 0.55, you can pretty much exclude Addison's on that basis alone. So second poll, and I appreciate that breed popularity may be quite variable across the world, but I wonder, are you familiar with any breeds that are particularly overrepresented with Addison's? And maybe these distributions aren't the same, and I'm interested to see the number of boxers that people are reporting with Addison's, because in the studies that have been performed in the UK and the US, they've been an underrepresented breed. So actually, strange that you're seeing so many dogs with Addison's that turn out to be boxers, because that's not our experience. Does anyone know the most famous owner of a Portuguese water dog? And even more impressive than that, if you can remember his name, the dog's name was Bo, and it belonged to the previous president of the United States, Barack Obama. And so we do have, we have people who knew that, so I'm very impressed with that level of knowledge. Anyway, Portuguese water dogs, they're predisposed. There's a genetic heritability to Addison's in that breed. So always on my list whenever I see these guys. Who else? Well, sometimes we'll see it in poodles and certainly in Leonbergers. But I'm fascinated by your experience that boxers are potentially overrepresented, because that's not what I've seen. And if we get to talking about Cushing's later on, that's where I would expect boxers to appear. So what further blood tests would you like to run? So we've got a high index of suspicion of Addison's in this dog. How are we going to confirm it? What test would you like to run to confirm your suspicion? And it might be a series of blood tests, it might be dynamic testing. How are you actually going to confirm your diagnosis? And remember, you think this dog has it, so I'm not trying to rule it out at this stage. If I was trying to rule it out, I might be looking at a basal cortisol. But as I suspect that would be low, it won't confirm it for me. It will just give me confirmation that it's got low basal cortisol. It won't tell me that it's got Addison's. So I need to do a definitive test. And for me, the test that I would be looking to do would be an ACTH stimulation test. Now, if you don't have access to synectin, and my understanding is that there are certain countries where the availability of synthetic ACTH for this type of testing may not be very high. I think that confirming the diagnosis can be very, very difficult. And actually, I'm not entirely sure how I would go about doing that, because therapeutic trials are inherently flawed. There are risks in doing that. And I think I would rely heavily on my leukogram and the level of lymphocytes. I wonder if Andy's got any ideas.
Well, I was just asking how many people have access to synthetic versions of ACTH, so synaptin or tetracazactide, and it seems a reasonable number if you don't have access to those things. So I think, we have had periods of time in the UK as well where tetracazactide was unavailable to us. And so I think there were patients who ended up being diagnosed based on clinical signs. And I guess we would combine, the electrolyte changes, potentially use of the lymphocyte count. And I guess you could kind of tick off, couldn't you, the things that make you, that are in keeping with an Addisonian. I think that in the less typical cases, or, if you've had cases that have had a load of fluid and their electrolytes are less consistent, then those are going to be the ones, I think, which would be very, very tricky to diagnose for sure.
I don't know. I think it is one of those things that we're very lucky to have access to these definitive tests, but if you don't have them, your confidence in diagnosis is going to be based on the clinical picture and probably ruling out alternative differentials for that animal's presentation. So I appreciate it's difficult. In this hypothetical situation, actually this dog presented on Christmas Eve, which is a national holiday in the UK, and one where we wouldn't have access to external laboratories that could run cortisol and post-stimulation cortisol, so we wouldn't be able to get those results for 4 days. And so I raised the question, would imaging help? Could you look at, for example, the adrenal glands and measure their size and try and say, is that a definitive test? Well, it's not. Because actually we will see small adrenal glands in normal healthy patients. So you can't rely on adrenal gland size as a marker of Addison's. I guess in a stressed patient, if I saw enlarged glands, maybe that would reduce my index of suspicion. I think you agree with that? Yeah. But I think there's so much overlap that I wouldn't be able to reach a diagnosis on the basis of adrenal gland size alone. Helpful to rule out other things, helpful to rule out the presence of free abdominal fluid and to rule out the possibility of duodenal perforation. Helpful also if you were doing thoracic radiographs to look for signs that confirm your hypovolemia. So is there microcardia? Is there a reduced diameter to your caudal vena cava? Those signs might further your suspicion of a hypovolemic state at least. And occasionally in dogs with Addison's, we will see a megaesophagus as well. So watch out for that remember, it's one of the differentials for megaesophagus. So if you're seeing a patient who presents for regurgitation, I would probably check for this condition. And in those situations, a basal cortisol would be a good way to exclude that as a diagnosis. What would you do about the hyperkalemia? Hyperkalemia can be a life-threatening situation in its own right, and it may need some steps to treat that, but often just aggressive fluid therapy to rehydrate that patient is going to be enough. So select your fluid carefully, and I would probably go for saline, but Hartmann's, which has a small amount of potassiums in it, would also be a safe selection. I wouldn't be overly concerned. You just want to, you don't need to supplement the fluid, obviously. Through dilution, it should quickly achieve a reduction in your serum potassium. In other situations, say you have a blocked cat that presents with hyperkalemia, fluid therapy may not be appropriate at high rate. And in those situations, you may need additional measures to support this patient. And that might include the use of calcium products, such as calcium gluconate, to stabilize the cardiac myocytes and reduce their reactivity to the hyperkalemia. So it doesn't actually bring the potassium level down, but it supports and protects the heart. And that's why we would use calcium in that context. And to try and help with bringing the potassium down, we would look to use, for example, a dextrose infusion, because as the glucose is taken into the cells, it's often co-transported with potassium. So you get the two leaving the bloodstream at the same time and going into the cells. And insulin, often administered via an infusion, can support that process. Short term, how am I going to manage Jasper in that acute phase? Well, I'm really going to be concentrating on rehydration. So fluid therapy would be the key. Once I'm confident of the diagnosis, I would want to introduce glucocorticoid therapy just at physiological doses. So what are the physiological doses of steroid? How much prednisolone would you want to give an Addisonian patient? What would be your sort of standard dose for management of an Addisonian for steroid? I would tend to adapt that. So while they're in the hospital, I'd probably be giving it more frequently and at a slightly higher dose than I would do once they are settled and in a routine at home. But if then something unsettling happens at their house, maybe they move, maybe there's a new pet that's introduced into that environment, then you might need to temporarily increase the steroid dose. And long-term treatment is going to depend on what medications you've got access to, but here we would be looking for a long-acting mineralocorticoid, or there are some short-acting drugs that are available as tablets, such as fludrocortisone, that can be used also to try and manage the electrolyte disturbances one sees with Addison's.
So I think there's a fair range of doses that people would reach for steroid, but I think we don't want to go too high, do we? Because these are the kind of dogs that if we give them too much steroid, actually we tend to see a lot of adverse effects, and a lot of the time owners, chronically with these conditions, the things that causes us most problems is excess glucocorticoid. So I think that's what we need to be a bit careful with. If anything, we often find ourselves giving less steroid over time rather than more.
So what would your starting dose be?
0.1, 0.2 mg per kilo, that kind of amount. And I expect that I'm likely to need to give less over time. Obviously, it does depend on your product because, and this is probably very much dependent on what you have access to in your country. We used to, in the UK, use a lot of fludrocortisone before we had access to the long-acting mineralocorticoids, DOCP. With fludrocortisone, it has some glucocorticoid and mineralocorticoid activity. So many dogs could be managed just on fludrocortisone rather than necessarily needing DOCP and extra prednisolone. The problem was with many of those dogs, because you can't then titrate the doses of that product separately, they probably ended up on a bit more glucocorticoid than we might ideally have given them. And so probably there were more Addisonian dogs who were, you know, a bit of an excess from that point of view than maybe we can achieve by using those products separately.
So that really is our whistle-stop tour of Addison's, and I think Jasper is a fairly classic case. That would be the type of presentation we would see that we would often describe as an Addisonian crisis. So he's come in pretty collapsed, unstable from a hemodynamic perspective, largely due to severe hypovolemia. And he will have been managed with aggressive fluid resuscitation. And actually, they do really, really well. So we would hope to have successful outcomes in 80 to 90% of these patients. That's a ice cream van coming around around the corner at the moment. We expect that they need lifelong management, but actually, as they do well, I would say Addison's is my favorite endocrine disease, and one that I would anticipate to establish a good relationship with the owner, because their dog should be a completely normal dog, provided we can maintain their normal hormonal balance through the use of these supplements. We're now going to change tack, and we're going to look at a different endocrine disease, and I think you'll work out quickly what we're doing. This is the opposite presentation to Jasper, and this is a little dog called Ruby. She's 11 years old, so classically a bit older. Addison's we see typically between 4 and 7 years of age, and often female neutered dogs, whereas in Cushing's they're typically older, and Ruby is your classic. She's in that 9 to 11 year bracket. She's actually 11. She's spayed, and the owners report that she's been drinking and urinating more over the last few months, and he's even nocturic. So she's waking them up to urinate or is peeing where she lies over the night. Now, your colleague thought that she might have Addison's and performed an ACTH stimulation test a few weeks ago, and that was normal. So actually, this is a normal response to an ACTH stimulation test, and does not suggest excessive adrenal function. So it does not indicate Cushing's. It tells you that the dog doesn't have Addison's, but it doesn't tell us any more than that. But be careful, because an Addison's, an ACTH stimulation test is a very, very good test for Addison's. And when it's positive, we can rely on its result. So it's got a high specificity. We're confident in a positive result, but we would very much question a negative result, because it does not exclude the presence of Cushing's. It has a low sensitivity, and we have to remember false negatives are going to be common. And remember, this test was done about 3 weeks ago, and this is Ruby's neck when she's come back in. And if you look carefully, you can see the shaved site for venipuncture. And what would you expect after 3 weeks? Our hairdressers reopened here last week, so I'm back to relatively normal. But over the last few months, I did have an explosion of hair, and it happens quite quickly. And dogs are no different, and we would expect reasonable hair regrowth within a 3-week period. So the fact that after 3 weeks, this site is still looks like it's been freshly clipped is an indicator of poor hair regrowth, which is one of the classic signs of Cushing's, because Cushing's does, or steroid, does have a significant influence on hair growth. So if this had grown back and we had to shave it again to get another sample, I would have questioned the suspicion of Cushing's, but finding it as bald as it was when we'd first clipped the hair says that Cushing's is maybe more likely. And that's one of the classic signs. We see a lot of alopecia in our Cushing's patients. So the owner's done some research, and more of our clients come in and they know the diagnosis because they've already been on Google, but they've done the research and they're thinking that the dog has Cushing's. And we start to investigate this possibility, and we do some routine bloods. Now, before we do that, before we look at those results, let's just see what you think of what tests would you use. And I'd be very interested, if you think that this patient has Cushing's, what test would you do to try and confirm that diagnosis? What's your preferred test? And looks like quite a few people do have access to an ACTH stimulation test. That's good. And there's nothing wrong with putting it depends, really, as I think that there are situations where people will decide this answer according to what's available, the logistics for the owner. Remember, a low-dose DEX test, which is a great test and a very sensitive test, takes 8 hours to perform. So if the patient comes in at 5 p.m. at night, you may not be overly keen to start that one and may reach for an ACTH stimulation test instead, because it's going to be done within an hour. High-dose dexamethasone suppression test is a differentiating test. It's got no diagnostic value, and you shouldn't be using that to try and diagnose Cushing's. Wait till you've got your diagnosis, and then if you're trying to differentiate between pituitary and adrenal dependence, then you can consider using a high-dose dexamethasone suppression test. What about a urine creatinine cortisol ratio? These are excellent screening tests, and I would use them when I don't think a dog's got Cushing's. So if the owner comes to me and says that they've read about Cushing's and they know that their boxer is predisposed to Cushing's, but it's a young boxer and has no compatible clinical signs, and I'm trying to demonstrate that the animal does not have Cushing's, then I want to choose a test that is very specific, i.e. very sensitive, i.e. has few false negatives, and I would therefore choose the urine creatinine cortisol ratio. But it is a poorly specific test, so if it's positive, it doesn't tell me very much. Let's look at the blood results. So these blood results, I'm encouraging you to have an idea. The reference to a UK game show called Play Your Cards Right, which was on TV when I was a bit younger. The idea is really just to see, do you think the ones that I've marked out would be below reference range, within reference range, or above reference range? It's not going to be in every case, but there are classic things that we might expect. And so think back a little bit to our Addisonian patients as well, because typically in a dog with Cushing's, we expect these to be the other way around. So we said that not unusual for an Addisonian patient to be hypercalcemic, i.e. to have increased calcium. Well, we can see low to low normal calcium in Cushing's patients, and that's through the effect of calciuresis. It encourages the animal to urinate out the calcium. Similar with urea, we might expect it to be low end because of this increased drinking and urination that they will be having. What about the liver enzyme activities? Well, ALT, mild to moderate increases is not unusual, but ALP often markedly increased. Anyone any idea why? What types of enzyme? There are different isoenzymes of ALP. So there's a liver form, there's a placental form that you might see in pregnancy. There's a renal form, there's a bone form. So it's not really that one that we're looking for. And we don't differentiate between them. They all get lumped together. But it's actually the steroid-induced form of ALP that we would anticipate to contribute largely to the increase in ALP that one sees in patients with Cushing's. Occasionally we'll see mild hyperglycemia, and not unheard of to see two concurrent endocrinopathies, so dogs that have both diabetes mellitus and Cushing's at the same time. Cholesterol and triglycerides, hyperlipidemia, well recognized in these guys. Flipping to the hematology, we might expect to see an erythrocytosis because steroids are involved in the erythropoiesis process. So not unusual to see a mild hemoconcentration, so a hematocrit at the top end or slightly above reference range. It won't be, you wouldn't expect to see polycythemia, but, or i.e. 65 plus, but it wouldn't be unusual to see it in that 50 to 57, 58 range, I would say. Platelets, we'd also occasionally see a thrombocytosis, so anywhere in the region of 450 to 600. And we are going to expect to see your classic stress leukogram because corticosteroids, cortisol in particular, contributes to that the formation of a stress leukogram. So that would be neutropenia, lymphopenia, and eosinopenia. So increased neutrophils, that's due to reduced margination. They'll come in and enter the vascular space. They won't actually increase in number, but they just become more detectable in your blood count, and your lymphocytes will go down and your eosinophils will go down. Urine analysis, we would expect the vast majority of dogs with Cushing's to have a low specific gravity. And often this can be anywhere from 1012 down to almost pure water, 1001. And when they're really low, that can be due to the excess steroid, but it can also be due to a macroadenoma, so your pituitary mass compressing the pituitary gland so that it no longer produces ADH, and you have a secondary diabetes insipidus. So if you get very, very low concentrations, I would consider that as a possibility as well. Urine sediment, we wouldn't expect to see white blood cells there because you're treating this dog, it's treating itself with corticosteroids. So that's an anti-inflammatory. So even if there's cystitis, you probably won't see a pyurea. You might though see some bacteria, and about 50% of dogs with Cushing's have bacteriuria. Don't treat it. I said this last time I talked about antibiotics. The presence of bacteriuria is not an indication for antibiotic use. We should be withholding that unless there are associated lower urinary tract signs. So if they've just got bacteria in the urine and they've got Cushing's, it's probably just one of those things, and treat the Cushing's and the dog will sort out the bacteriuria if as appropriate. Wouldn't be unusual, about 50% of cases will see calcium oxalate crystals. Remember I mentioned the calciuresis that goes on. That excess of calcium in the urine leads to supersaturation and the formation of calcium oxalate crystals. And again, we'll see an increased UPC. And this can be anywhere from 0.5, which is top end of normal, right up to 5 or 6. How high have you gone with your UPC in a Cushing's patient?
Yeah, not much over that probably, but certainly they can be, at levels that otherwise you would be concerned that they had some kind of nephropathy. I guess hypertension sometimes contributes to that in these Cushingoid patients as well.
Yeah, definitely I would be recommending checking blood pressure in these dogs. We're now convinced that Ruby has Cushing's and we want to do a definitive test. Remember the ACTH test was negative, so we've reached to do a low-dose dexamethasone suppression test. And we've got 3 hypothetical dogs. There's the blue one, the purple one, and the green one. What are the diagnoses? So let's start with the green line. What is the diagnosis for this dog who's got a increased cortisol at T0 that suppresses into the normal range at T4 and at T8? So the dog with the green line on a low-dose dexamethasone suppression test, does that have Cushing's? If he does have Cushing's, is it adrenal dependent or pituitary dependent? Or is that a normal dog? So that one is your normal dog. That's the healthy response. That remember at T0, the point of a low-dose dexamethasone suppression test is that you've injected dexamethasone. And that should cause negative feedback and therefore reduced endogenous production of steroid for the next 8 hours. And it's the diagnosis is based on your T8 reading. So if that suppression of cortisol production is maintained at 8 hours post injection of dexamethasone, then, and if it's below that 40 nanomoles per litre threshold, your dog does not have Cushing's according to this test. If, however, it's escaped and it's above that threshold, then that is consistent with Cushing's. So both the purple line and the blue line are consistent with Cushing's. What's interesting is whether we can use T4 to differentiate between whether it's a pituitary dependent or an adrenal dependent problem. And so you can see that actually the purple line did suppress transiently. So for 4 hours, there was a reduction in the cortisol level. And that we will sometimes see with pituitary dependent Cushing's. Not always, but some of those dogs, about 60%, will suppress at 4 hours. So this line could be your pituitary dependent, and well, would be pituitary dependent Cushing's. And the blue line, which hasn't suppressed at all at either 4 hours or 8 hours, is Cushing's, but we don't know what form. It could be adrenal dependent, because adrenal dependent will never suppress. So adrenal dependent couldn't be either of the other two lines, but it still, because actually pituitary dependent is more common, it still could be pituitary dependent Cushing's. And so these are Ruby's results, and you can see that she was high at T0, and despite injection of dexamethasone, it's actually gone up. And so there was no suppression whatsoever, and she's got Cushing's. And actually we can't tell at this stage whether she's got adrenal dependent or pituitary dependent disease. So how could we differentiate? If we actually wanted to get this answer, how could we differentiate between pituitary dependent and adrenal dependent Cushing's? So high dose dex is a good idea, but it is still not perfect. And if you have no suppression and a flat line curve like our blue line curve, even with a high dose dexamethasone suppression test, it's still a 50-50. So remember, we want to know if she's got an adrenal dependent problem. It's not perfect. You could aspirate the adrenal gland. You have to be quite brave to do that. There is a recent paper out suggesting that you can get away with that, but I always get a bit twitchy about doing adrenal gland fine needle aspirates, because you could be leading to something of a hormonal surge in your patient, and I'm not sure that that's always going to be well tolerated. And it is also a very technically challenging thing to do, to even find the adrenal glands, let alone guide your needle into them. So be brave to do it. I think abdominal ultrasound is useful, because if you see marked adrenal gland enlargement, and in particular adrenal gland asymmetry, then that would be suspicious of an adrenal dependent form. And also the use of endogenous ACTH, well, that can be very useful because it can be differentiation, can label differentiation. There is a grey zone in the middle, which we can't interpret, but if you had high ACTH, well, that's going to be pituitary dependent, and low ACTH through negative feedback, that's going to be consistent with adrenal dependence of your Cushing's.
I guess challenging the sampling of endogenous ACTH, isn't it? That's one of our tests that is quite difficult for us to submit. So maybe one that is less available anyway to many people.
Yeah, I agree. And not one that we routinely use anyway. No. And this is our ultrasound image, and you can see the kidney just on the right side of the screen, and the large adrenal mass, and that was consistent with a adrenal dependent Cushing's, and that was the final diagnosis in this patient. I guess it could have been a pheo, that would be a pheochromocytoma, that would be my other differential for an adrenal mass in a small dog. So what treatment options? Now we know, and I can tell you that we did actually manage to run endogenous ACTH, and that was low. So we've diagnosed Ruby confidently with an adrenal dependent Cushing's. How would you treat that? What are you going to offer the owner? And that again may be what's available in your country. Anyone reaching for surgery, would you want to consider that? How confident would you be to do that? Would you anticipate that the patient will do well post-operatively? I think it's a surgery that once treated, it's curative in a lot of cases. So yes, it can be, they can do really well. I guess you do have to be a bit cautious because we're talking about 30% mortality with adrenal removal, and that may be a bit operator dependent. So if you're doing it for your first time, you probably want to get backup and some anesthetic support because then it's a complicated surgery. And even in specialist hands, we can look at 50% morbidity as well. So post-operative complications like poor wound healing, pancreatitis, hemorrhage, very common. So I'm not sure I would jump to that, and I would probably reach for medical management initially. Don't know what suggestions have come through.
Mitotane as a possible, which I guess we don't use a huge amount of now in the UK. Certainly we would have used that a few years ago, but I think that's largely been replaced, isn't it, by the other alternatives that we have access to. Not much else in the way of suggestions, to be honest.
Well, we tend not to use mitotane. I have used it once in a dog with a metastatic adenocarcinoma of the adrenal gland, but we would tend to reach for trilostane. Trilostane would be our treatment of choice. It's an enzyme inhibitor that blocks the production of cortisol by the adrenal gland. So it's not actually treating the tumor, it's just treating the excess of steroid, and therefore should minimize those associated clinical signs. And I would certainly treat.
Some people reaching for ketoconazole is the other one.
Ketoconazole,
Which again, we don't use much over here, do we? But it is reported for sure.
I'd be fascinated to hear some of the your responses. How well do these dogs do with ketoconazole? Do you get sustained response?
Yeah, I can't say I've definitely never used ketoconazole to treat a cushingoid. So do put in what your experiences are with using it. We'd be very interested to hear those.
Yeah. I mean, we use ketoconazole very, very rarely now as an antifungal. Sometimes people use it to try and reduce their requirement for cyclosporin because it can help by blocking certain metabolic pathways. It can increase your concentration of cyclosporin in the blood. But I've never used it for Cushing's, and I'd be fascinated to hear people's experience with that. The prognosis for Ruby, I think you need to be realistic with the owners. This is a challenging condition to treat. And actually, with medical management, most dogs only go on for a year or a couple of years at most. So they will succumb to the long-term effects of excess endogenous corticosteroid. And I think this is something that motivates me to be more aggressive with my therapy. So we both said earlier on that if we had a choice of endocrine disease, we would go for Addison's. And I think that one of the reasons that people undertreat Cushing's, certainly in the UK at least, is because of fear of developing Addison's. And those two statements don't stack up. If you're saying that Addison's is a treatable and manageable disease, why don't you treat Cushing's a bit more aggressively to manage that condition better? I think it's a question of longevity, and we don't like immediate adverse effects, but actually we would probably be better off pushing them a little bit harder and getting their levels lower so that they had a better quality of life and a longer experience. So that's now the way I try and approach these. I don't know if you do that as well.
Yeah, for sure.
And we do try and manage these such that they can have a good quality of life and minimal adverse effects associated with the Cushing's. In terms of monitoring treatment, primarily it's on clinical signs, though there are blood tests that you can do to monitor the efficacy of your treatment as well. I will skip out this question, and I really just wanted to finish with a thank you to everyone for participating. We are very keen to get your feedback. It's something that we've actually run already in the UK. We ran a series of sessions about a variety of small animal topics. Both of us are small animal medics, that's our only limited expertise, but we're interested to hear other people's experiences. We're very happy to offer to do other talks on subjects that could be of interest and of relevance to people. So if you do have any ideas, put those suggestions out, and if there are topics that you'd like us to consider covering, we would be very open to that, and we would welcome any feedback in the relevance of the questions and the information that we've provided today, and also in the format, because we're not sure how many people were able to engage in the breakout rooms. Is that actually something that's helpful? Is there ways that we could improve that? So we would welcome that feedback as well.
One of the comments that we're getting a little bit here about treating these dogs is how we kind of follow them up, what we might do in terms of monitoring, particularly if you're using trilostane, for example. And I guess for me, there's two things in terms of monitoring Cushingoid patients. Fundamentally, the most important thing that we're kind of aiming for is really controlling clinical signs. And so, you know, when we look at how effective our drugs are, actually whether they're working, whether they're doing what we want them to do, is usually quite clinical. Have we resolved the excessive drinking, urination, polyphagia, all of those kind of things? Most of our monitoring blood work is really a bit of a hunt to make sure we're not over suppressing the adrenals. And what you do in that situation is probably dependent on what you have access to. It's one of those areas we've changed a bit over the last few years. We've moved away from using things like ACTH stimulation tests for monitoring many of our dogs, and we now use so-called pre-pill cortisols. And really, we're just looking that those dogs have an adequate kind of adrenal reserve when they're on treatment. And we tolerate them having fairly low levels of cortisol, really. You know, as Fergus says, we if anything, are probably more aggressive with the way that we treat them these days. But you know, really, it's clinical signs that are our most useful thing in terms of monitoring those dogs over time, which is why we need to make sure that those dogs have compatible clinical signs in the first place before we go down the road of trying to diagnose the disease. Otherwise, it becomes a very tricky thing to monitor.
Yep, and if you've got further questions, do post them, and we'll stay here for the time being just to try and answer any additional questions you have on the two cases from today. And as I say, thank you very much to everyone for your participation in this clinical club.
Thank you very much, Andrew and Fergus. I think we've seen the greatest teamwork there. One speak and one answer the questions through the chart. So thank you very much, everybody, and thank you for these two brilliant speakers. And I think I sent out our link for the feedback, ECVIM feedback form. So there are 5 questions. So here you can feel free to give some feedback on the content, the topic as they mentioned. So it's very much appreciated. We basically just learn together through the journey. I think today we had some like technical issues. I think some of you cannot open the PDF file. So next time we learn from the mistake. We next time probably send a link instead, yeah? So we probably have another like 15 minutes. So please feel free to like raise your hand and or post your question in the chat box. So so Fergus, Andrew will kindly to answer your questions. Yeah. Have you seen any question that you're quite interested in, to answer?
There's a little bit I hear about primary versus secondary Cushing. I guess maybe talking about iatrogenic Cushing's. So certainly we see a reasonable amount of iatrogenic Cushing's in patients that we treat with steroids, and primarily that's something we diagnose based on presenting signs in clinical history. We know that they're dogs that we've whacked with a load of steroid usually, and obviously the primary treatment for that is trying to withdraw the steroid where we can. Sometimes that can be quite challenging. You know, we often see it in dogs with you know, severe autoimmune diseases, for example, where we're having to use high doses of a steroid. And we can end up in a slightly tricky situation where we kind of feel we can't necessarily withdraw the steroid, but the dogs have issues associated with that steroid use, and there's no easy answer to that. Sometimes it involves you know, changing to alternative immune suppressing medications, for example, but that's certainly a tricky situation to be in anyway.
Neither of us are ophthalmologists, so we're not going to be able to help you with that on that front. Sorry for that suggestion. I think there would be some really good ophthalmologists out there, and hopefully we can get somebody for you. But Cushing's in cats, not dissimilar, but there are some really important differences. Cushing's in cats you will see and diagnose in poorly controlled diabetic cats. So nearly all the cats with Cushing's have been previously diagnosed with diabetes. The other major presentation is what's called fragile skin syndrome. And these are cats that you go to stroke and you rip holes in their skin. And so it's a very dramatic condition, and it has, well, it's very difficult to treat. I've never actually managed to successfully treat a cat with Cushing's. The vast majority of cats that present are in a terminal state, and we're not actually very good at managing that, unfortunately.
Hello.
Hello.
I think I've unmuted you. Can speak now.
Yes, do feel free to speak.
Hello, Uba Gold. Uba Gold, you can speak.
Go for it, Uba.
Okay, I wanted to ask, what's the difference between primary Cushing syndrome and secondary Cushing syndrome?
Sorry, I didn't
What's
hear.
the difference
actually.
between primary and secondary Cushing's?
Do you mean iatrogenics? I think we covered. I don't know if you heard the answer just now, but I think secondary Cushing's. I guess you're referring more to iatrogenic Cushing's. I think that's the case. So the difference with iatrogenic Cushing's is that it's usually caused by us giving lots of steroid.
Does that answer your question? Is that what you mean? Because sometimes people think of secondary Cushing's as being excess CRH production, don't they? Triggering, and that...
I don't think that's even reported. Is it not more of a theoretical...
Yeah, I think that's sometimes described in humans, but I've never heard of it in dogs or cats. So if you mean, is there, obviously ACTH stimulation or production is controlled by corticotropin releasing hormone. Finish on right with that. So yes, you could have an excess of that hormone that triggers your excess of ACTH, but I'm really not aware of that being reported in dogs.
Okay, but some are congenital, right?
What? Sorry.
Could you ask your question again? Say that remark again.
I asked if some are congenital.
Congenital Cushing's.
Congenital Cushing's is really rare. I'm not even sure if it exists. Congenital Addison's exists, but remember, Cushing's by definition is an excess of steroid hormone, and that's either produced by a tumour of the pituitary gland or a tumour of the adrenal gland, or exogenous administration of steroid. So I don't see how that would arise as a congenital condition.
Have you come across a case you were suspicious for this? think we might have lost you, Uber. Well, you're back, I think. I can see you moving again. Did you think you'd come across a congenital Cushing's?
She's muted now.
You might be muted now.
Yeah. We're back on. You're back in.
You're back on.
Yeah, I've unmuted Amiru.
Oh, lovely.
Hi.
Hi, Amaru.
Go with it. Go with it for your question, Amaru.
Okay. Thank you very much for the lecture. Hello? Hello?
Hello.
Hello.
Thank you very much, sir, for the lecture. I just want to know how ketoconazole reduces the level of steroid in the blood.
How do we measure the level of steroid in the blood?
Yes, how ketoconazole, that is the antifungal drug that you had just mentioned. How does it reduce the level of steroids in the blood?
I can't remember, actually. I'll be honest, I can't remember.
I think it has direct effects on the adrenal gland, doesn't it? And it damages the adrenal gland such that steroid production is impaired. So I think it's blocking steroid production. It's not damaging the tumor, if that makes sense.
Okay, thank you, sir. Thank you very much. Thank you.
Is that what you use? Might have gone.
There was a comment here by Cameron, which I think is a good one, about how we ought to probably be looking for Addison's in dogs with chronic enteropathy. And certainly I think it's a good point that essentially these most commonly atypical Addisonians, the ones with normal electrolytes, can look identical to the patients with chronic enteropathy. So there is definitely a school of thought saying that we should be ruling out that disease in these kind of chronic gut disease patients. That's where basal cortisol, I think, can be useful. If you don't have access to ACTH, just running a basal cortisol, hopefully if it's over 55 nanomoles per litre, then you can exclude that disease.
2 milligrams per milliliter.
So I've unmuted Faye Angela.
Hi, Faye.
Hello, there's the possibility of having Cushing's rises if the dog is crossbreed.
It's crossbreed. No.
I would think, if anything, it might be lower in a crossbreed. I mean, we see it in a variety of breeds, but it's always very difficult to look for prevalence in crossbreeds. They often don't feature very heavily in studies because people tend to focus on things that are easier to describe, i.e. pedigree dogs.
For me, boxers are the most common breed for Cushing's. I see a lot of boxers with it. Yeah. We do also see miniature schnauzers. I've seen a few of those. Mm-hmm. What else have we seen?
A lot of the pituitaries are little terriers, aren't they? Yeah. Jack Russells.
So there is a...
How about Dachshund?
Dachshund as well, yeah.
Dachshunds, yes.
Pituitary dependent, the majority are going to be less than 20 kilos, and about half of the adrenal dependent are over 20 kilos. So if you get a big dog, I'd be more suspicious, and I'd certainly be more cautious as to the possibility of adrenal dependence.
Okay, thank you so much.
Good to see you. Do we have any more hands?
So I've unmuted Mansu Nuhu.
Great. Hi, Mansu.
Hi, Mansu. Hi, Mansu Nuhu. You can speak. Let's try another one.
Hello.
Hello.
Am I audible?
Yes.
You are live across the world. What's your question?
Thanks a lot for providing me with a stage. Okay, my question is very basic one. Actually, with lots of endocrinopathies, we come across certain good articles. But what about the reference ranges? Let's, for example, if we talk about the pre-renal, post-renal, and renal. So even the articles stand in contradiction with each other when we talk about the specific gravities and all. So I just want a reference from you, that which is the most reliable, or which one you follow as a reference range when deciding this.
So urine specific gravity does vary a lot, and you have to be very careful.
First of all, sorry to interrupt you. You agree with me this on this question or not? Because I feel it quite difficult when you read on to one article and then you switch on to other book. One says the one thing, another says the other. So which one to follow?
I agree, and you have to be careful the sources you rely on. But one thing I would say with urine specific gravity, which you mentioned, is that there is a lot of variability. And you know this from personal experience. If you drink a lot of water, you have dilute urine. If you haven't had a drink for a long time, you have more concentrated urine. And because of that inherent variability, it's harder to give definitive ranges. What's important in terms of dogs with Cushing's or with Addison's is that the majority will have consistently dilute urine. So every time you measure it, it will be less than 1020 in terms of specific gravity. So I would find it unusual to test the urine of a dog with Cushing's and for it to be concentrated. So if it's 1025, 1030 and above, that would be very, very rare in Cushing's. If it's less than 1020, it doesn't mean it's got Cushing's, but it's a consistent finding. Is that what you mean?
Okay. I got you. That we have to perform a series of tests in order to just be very sure about our diagnosis.
Yeah, and I think it's important, isn't it, that urine specific gravity for me is not that kind of, we look at this once and that gives us an answer. We have to really interpret that as part of the...
Sorry to interrupt you.
Not at all.
Hello? Sir, it's not only about the urine specific gravity. Actually, I'm talking about like cortisol level, and when we are talking about hyperparathyroidism, the values, the reference ranges. I am asking you about the text or any commendable source on which we can rely.
I think one of the really important things, if you look at things like cortisol, is actually a lot of that comes down to what particular assay your lab is using. So the best source of information about what you should expect to be normal or abnormal in your patients is going to be your lab, because all of the assays behave in a slightly different way. And that's why it can be quite difficult to directly take the results of one study performed on a particular analyzer and copy that across to a different analyzer. So, that often explains why things can come out a little bit different in similar types of publication, because they may use a slightly different cortisol assay, for example. So I think you need to know what is normal for your lab using the analyzer that they use.
Okay, thanks for the healthy advice.
Thank you.
No problem. There's a couple more hands, isn't there?
Yeah. So, Vedura.
Hello?
Hello.
Can you hear me?
Yeah. I can hear you just about.
Can you hear me?
Just about. You're speaking without moving your lips. It's amazing.
I'm from Sri Lanka.
Oh no, I think we've lost you.
Yeah, hello.
Yes, that's better.
Hello, I'm from Sri Lanka. I have a small question. In Cushing syndrome, we can significantly see a pendulous abdomen. Is it significant or?
What was the question? Do we see a pendulous abdomen? Yes, it's very common for us to see a pendulous abdomen in patients with Cushing's. Dogs and cats. We spoke about how rare it is in cats, but cats are quite nice if they have Cushing's. Often if you hold them upright like this, they develop a little pear shape because of the pendulous abdomen. There's various factors that contribute to that pendulous abdomen in dogs and cats with Cushing's. Number one, the liver tends to get big. Number two, they tend to have weakness of their muscles, and that just encourages everything to hang down. So yes, pendulous abdomen, very, very common, and sometimes can be quite marked.
Good point.
Cool. Who's next? Carl Leonard. Carl Leonard.
Hi.
Hi.
Hi, Carl.
Yeah, thank you for the great presentation. I just would like to ask, although the disease Cushing is associated with several comorbidities, for example, obesity or hypertension. Now, how are we going to prepare to delve a little deeper in seeing the signs or symptoms to see if these patients warrant a screening test for Cushing's disease?
Good question. I think that for me, the clinical signs that make me suspicious of Cushing's are the classic triad of excessive drinking, excessive urination, and a voracious appetite. So if you've got an older dog, typically 8, 9 to 11 years of age, who's showing those signs, I would be thinking of diabetes or Cushing's. So if they're losing weight, I'd be more inclined to think of diabetes. And if they're gaining weight or maintaining their body weight, then I would be suspicious of Cushing's. There might be other signs, like it was just mentioned, the possibility of a pendulous abdomen. You might have poor coat quality. You might have panting. And I think that those clinical signs warrant further investigation, and your index of suspicion will increase as you see those classic biochemical changes that we talked about earlier on.
Okay, thank you so much.
No problem. Vijura, I think, lost his connection just as we were answering his question. So yes, to reiterate, pendulous abdomen, very common in Cushing's patients, typically a combination of a big liver and some muscle weakness. So everything hangs down as a result. But yeah, it's one of the more common clinical signs that we would see.
Okay, great, thanks.
So I found, oh, whoops. Try again. Diam Gaba. Yeah.
Hello.
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 Hi.
Hello.
Hello.
Hi.
I'm Muhammad from Nigeria.
Hi.
Hi, Mohammed. Great to have you here.
Okay. I have a little question that I want to ask.
Go for it.
Okay. If a aged dog is having polyuria and panting, gaining weight, so what should I suspect then?
I think you should do some tests if you can. So if you could do blood work first, and if you increase your suspicion of Cushing's, then it may be appropriate to treat. But I think it was rare that we would diagnose Cushing's or start treating Cushing's without doing some diagnostic tests. So I would try and get a urine sample and see how dilute it is, and rule out the presence of glucose, because diabetes is a more common endocrinopathy. So I would check for that first. And if you've got glucose in the urine, then you'd be able to diagnose diabetes quite quickly.
Okay.
If you've got a very dilute urine, then I'd try and run some blood work. And if that was consistent, I would, if you can measure cortisol, I would do a low dose dexamethasone suppression test to try and confirm your diagnosis.
Okay, thank you very much.
No worries. Good luck with it.
Thank you.
And hi to your little friends.
Hi.
So I think maybe we've got time for about maybe one more question, something like that.
Yeah, sounds good. I found Milton Muhammad Fadu. Muhammad Fadu.
Yes, good afternoon.
Yep.
Good afternoon.
Good afternoon.
My name is Muhammad Fadil Rilwan from Nigeria.
Hello.
Hello?
Hello.
Hi. Great.
Hello, can you hear me?
Yes, we can hear you well.
Yes.
Yes, my name is Muhammad.
Hi.
Yes. My question is, in the case of fusion, when adrenal adenoma tumor is not identified, can the removal of one of the adrenal glands be done so that to reduce the excess production of the cortisol?
So your question is kind of, could you remove one, if you've got a pituitary dependent Cushing's, could you remove one adrenal gland? I think the problem that you would have is that because you've got these excessively high levels of ACTH, the other adrenal gland would just hypertrophy, and so you would end up with the other one taking over from that job. So it is described, and we don't do it very often, but bilateral adrenalectomy, if you wanted to manage the disease through removing the adrenal glands, you would have to remove both, and then treat that dog as an Addisonian. But that it's not commonly done for that reason. But I don't think removing a single adrenal gland would achieve what you would want it to, unfortunately.
Okay. Because there will be compensatory hypertrophy to the other adrenal gland. When one is
the other adrenal, because the problem is that those adrenal glands are being stimulated.
When there is excess production of cortisol, then there should be a negative feedback so that the excess production of cortisol can be stopped.
There should be, and in a normal dog, that's exactly what would happen, isn't it? In a normal dog, your cortisol production would have a negative feedback effect on the pituitary, but because we've got overproduction of that ACTH, which in most dogs is a pituitary microadenoma, that doesn't respond to the negative feedback. So you've lost that negative feedback loop.
Okay, so thank you very much.
Good question, thank you.
Yeah, thank you very much.
Great. Fantastic.
Thank you very much, everyone. Thank you very much, Fergus and Andrew. Hi, can I have a final reminder that I've shared the link for our feedback form. Your feedback will be very important for us to build other future lectures. So from now, what I can see, the response, I realize that many of you don't know what XVAL is. So probably later our XVAL doc will play a video, and that will help you understand what we do and how we make difference. And finally, as a tradition of the XVAL lecture, can I ask everyone to turn on the camera, and our XVAL doc will unmute everyone. So could you please speak out to express your thank you. Thanks for everyone. So first of all, we need to thank Fergus and Andrew, and also our future vet pathology club. And most importantly, a big thank you for everyone who participated, who has been so patient. We all over the world during this pandemic. It's a very unstable internet. So amazing that is we together for 2 hours.
Thank you.
Yeah,
Thank
we
you,
can all
Alice.
be proud of ourselves.
Thank you.
Thank you.
Thank you, Andrew.
Thank you.
Thank you to XVAL.
Thank you as well.
Thank you. Lecture.
Thank you.
Enjoy the lecture. Thank you very much. See you soon.
Thank you.
Thank you so much. Thank you.
Really appreciate you.
Thank you. Thank you.
Enjoyed everybody. Thank you.
Great. Thank you so much, everyone, to come in again. Thank you so much, Andrew and Fergus, to give amazing
Thank you
lecture.
so much. Thank you.
I don't know if you can hear me anyway.
Thank you so much.
Yes,
Well, it's always amazing to see all these faces.
Thank you.
Thank you.
Thank you.
So thank you, everyone. We will see you next time. There's as I mentioned, the 4 lecture already has been arranged. So please check out. So please take care, everyone. Be safe and be happy. Yeah. See you next time. Bye.
Bye.
Bye. Thank you. Bye.
Good to meet you.